Welcome to this Audiocast, produced by the Minnesota Department of Health Healthcare Homes Program.
Good morning. This is Carol Bauer from the Healthcare Homes Program, and we're talking with Trent Bullerman, RN Care Manager and Care Coordinator for the Sanford Clinic in Laverne, Minnesota. Laverne is a rural community in the southwest corner of our state. The topic today is care coordination stories, what I know now that I wish I'd known when I started. Good morning, Trent. Thanks for joining us.
Good morning.
So, Trent, I'd like to start by talking about how you came to be a care coordinator. We've observed that care coordinators come from a variety of backgrounds. What's your story?
So I have a 4-year RN degree, and then after that, started at the hospital here in Laverne on the hospital side versus the clinic. And then from there, I actually did some home health out in Colorado. And then when we moved back, we started on the clinic side and primarily worked with one of the family docs who was really involved with the care coordination process and medical home. So when our care coordinator position came open, she just felt like it would be a good fit because it's something that she had pushed and I was pretty familiar with it, just having a doctor that was kind of the champion of that process.
Well, great. Well, I'd like to learn more now about your clinic population in your community. Are there unique challenges that you're addressing in Laverne, and what does that patient population look like?
The population of Laverne is about 4,500 and primarily white English-speaking. We're a very rural community. We do have some Spanish and Arabic-speaking patients. We pull those from, there's a community not too far away that has a packing plant, so we do pull some of those patients from there as well. And then part of our struggle, I guess, with the community is transportation. Being a rural community, some of the patients who don't have the funds to, say, get to Sioux Falls or something like that, if they need to see a specialty doctor that we can't bring here.
Okay, so as you look at your population, how are you identifying and enrolling patients in care coordination?
When I first started, the program was already going here, so initially I had kind of inherited some patients from our previous care coordinator. The doctors are very good with bringing patients to us, and they're kind of all on board with the program. But then recently we've started looking for the patients a little bit on our own, just using a risk stratification score, and anybody over an 8, we try to reach out to those patients.
That's fantastic. So what are some of those risks you're looking for?
So the risk stratification is the criteria. Part of it is age, and then hospitalizations, and then the number of ER visits, like if they have had so many ER visits in the past couple months. Some of the chronic diseases, if they meet those as well, like if they have blood pressure that's not well controlled or diabetes. And then depression and anxiety is one, too, that those scores come up. It's been a really helpful tool. Some of those patients we were already meeting with, so it was nice to see that we were catching some of them, but then it's also been really nice to catch the patients that we probably wouldn't have caught before that.
So as you think about your care coordination story, what do you remember as being especially challenging for your team and for your patients when you got going? And then what did you do to address those challenges?
So when I first started in the position, we didn't have a lot of support staff for it, so you were trying to kind of had your hand in a lot of different things, but probably wasn't spending as much time as what I needed to on any of them. And then we got a grant and brought on a CCA or a care coordination assistant just to help with working our chronic disease registries and seeing patients or finding patients that are overdue for appointments, and just if they're missing something, kind of help contacting those patients and doing a little bit of pre-visit planning.
It was really different when you first started out. So how has it changed your practice over time, and what are you learning?
You see those patients, and every now and then you'd have a patient that maybe is struggling with taking their medications or compliance or something like that. So you're used to going from a position where most of your patients are doing the things that you ask and the things that they're supposed to, where now you're in a position where you're getting the patients that are struggling with those things referred to you. So there's just a learning curve for me going from having all these patients that listen and they do all these things to patients that struggle with that.
I've got one more question for you, and that question is, looking back, what advice would you offer to clinics that are early in their care coordination journey? What do you know now that you wish you'd known when you started?
Probably one of the biggest things is that you're not alone in the work that you're doing. When I first started trying to do all these things individually, like working the registries and doing some pre-visit planning and doing a lot of these things, but probably not spending as much time on them as what you should. After a little while, we went to the nurses meeting and asked certain nurses if they would take over like one chronic disease or something like that to kind of help us manage or just decrease that workload a little bit. So it did work out really well for us to do that. And then a big part of our job too is the quality metrics and providing that information to the providers and how do we work on that. Would run our diabetes registry, for example, and then I sorted kind of by the patients that were doing the worst and wanted to start with those because I thought that was how I was going to impact things. Where quality numbers wise, it was nice to actually start with the people who were maybe just missing one thing and kind of your low hanging fruit, and that really helped our diabetes scores, like focusing on those patients that only had one gap rather than the ones that are missing 3 or 4 things. And that's, since we've kind of changed that focus, our quality numbers have come up quite well, and we've applied that focus to all of our quality metrics. And then another thing I would say is that with the position, you do work with a lot of challenging patients, so that when you do have a patient win, make sure that you celebrate that. I know one of our latest wins is the goal for colorectal screening is 80%, and that's something this last year that we worked really hard on, and we hit 80% for that last month.
Oh, that's really great. So congratulations on finding a strategy that works for your clinic and for your patients. And it's really great that you're celebrating your wins, because that's hard work, isn't it?
Yeah, and it's sometimes it can weigh on you a little bit, but like I said, when you have those wins, just make sure that those are kind of the things that you're focusing on. And it can be, patients can be really appreciative, and you can really change some lives doing that.
That's fantastic. Well, Trent, thank you so much for being with us today and sharing your experiences with us. We all learn best when we learn from each other, so thanks so much for sharing.
Please visit the Minnesota Healthcare Homes website for more resources to help you deliver patient-centered, team-based care. Thanks for listening.